Hello friends, welcome to yet another episode of NEET PG Concepts. I am Dr. Shadab Jafri and I am CMO at CHS Lucknow. Now, of late we have been discussing about ECG and various tachyarrhythmias, AVNRT, AVRT, PSVT. So now today we'll discuss another important topic, atrial fibrillation, but in relation to question wise in a retrograde manner because retrograde study is always beneficial for a competitive examination like NEET PG, inicet. So we will solve some questions one by one and we'll see. And we have started a new series which we'll be discussing now. Now, coming back to our first question. Now, as you know, we are starting with this new series, multiple question and one answer series. So that will help you to understand the concepts better. That examiner can ask the same question any way and the answer will be the same. Now, coming to the first question. 65-year-old obese patient presented with sudden onset palpitation. An ECG was done which showed irregular fast heart rate with ECG, which is given below. BP is 110 by 70. What is your diagnosis? Now you can see here clearly in the ECG that the ears are not visible, the heart rate is irregular, and the QRS complex is narrow. So it can be either PSVT or it can be atrial fibrillation. But as you know, PSVT is a regular tachycardia, uh, and atrial fibrillation is irregular. So the answer here will be atrial fibrillation. Now, what is the management? What should be the management of this atrial fibrillation? Now you see the BP is given 110 by 70. That means the patient is stable. Now, what do you mean by the patient is stable? Patient is stable means hemodynamically stable. BP is normal and no chest pain, no dyspnea, no no any altered mental status. So this is known as a hemodynamically stable patient. And such patients, we have two options. First, we have to control the rate because the atria are throwing very fast impulses and all the impulses cannot be conducted to ventricles. But if maximum impulses are conducted to ventricles, then the ventricle rate will increase dangerously. So we have to control the ventricular rate in such cases, and that is our first priority. And we have the AV nodal blocking agents like beta blockers, verapamil, DTSM, and all those. So those are very very important for us. And we'll also further deal in our lecture that acute atrial fibrillation and chronic atrial fibrillation. So what is the management part? But here the question has four options, and the four options, which is the best option? The best option is beta blockers. Now, as you can see, that other options are apixaban, cardioversion, and pacemaker. So, apixaban will lead to anticoagulant, is an anticoagulant, and anticoagulant. We use anticoagulant in atrial fibrillation, but the scenario will arise when we know whether it is acute atrial fibrillation or chronic atrial fibrillation. That we'll deal later on. So, for now onwards, the answer is beta blockers. And why not cardioversion? Cardioversion we do in unstable patients. And pacemaker is an absurd answer. So pacemaker is not an answer. So you see, this is how you can diagnose a case of atrial fibrillation, and then we'll proceed for a management further on. Now coming back to our second question, a 67-year-old alcoholic presented with low BP, 80 by 16 emergency, and ECG was done, which is shown below. What is the diagnosis? Now you can see here that now there is no narrow complex tachycardia. The tachycardia is there, but it is a wide complex tachycardia. Now, a wide complex tachycardia can also be a ventricular tachycardia, or it can be a atrial fibrillation. A pre-excited atrial fibrillation can also be there. So now you see here what is the diagnosis in the four choices which are given. So here also the answer is atrial fibrillation. Now, why not ventricular tachycardia? You see, the ventricular tachycardia mainly it is a monomorphic ventricular tachycardia, which will show the concordance in all the leads. 1, 2, 3, AVL, AVR, AVF, similar morphologies in all the leads. But here you can clearly see that in some of the leads, the morphology is different. So this is not a case of ventricular tachycardia, this is a case of atrial fibrillation. Now, why not PSVT? Why not VF, ventricular fibrillation? As you know, then PSVT, it is a narrow complex tachycardia, and here you can see it is a wide complex tachycardia. So the answer cannot be PSVT. And why not ventricular fibrillation? Because in the ventricular fibrillation, the baseline is very varying. So ventricular fibrillation cannot be the answer. Now, what is the management? Now here you can clearly see that the BP of the patient is down 80/60. So here cardioversion is the answer, and that this concept you have to keep in mind. This is always asked in an entrance examination, and this you have to know because rest you will know when you become a PG student. Before becoming a PG student, you must know these concepts, which are very important. Now, coming back to the atrial fibrillation, what is atrial fibrillation? Atrial fibrillation is the most common sustained arrhythmia which we see in our OPDs. OPDs में बहुत कॉमन है आप बहुत पेशेंट्स को देखेंगे कि उनका बीटा ब्लॉकर चल रहे हैं डिल्टियाज़म चल रहा है और उनका एंटीकोगुलेंट वारफेरिन चल रहा है so all these things are very commonly you see in the medicine OPD. So now come back to a brief discussion about what is atrial fibrillation, what are the clinical features, and what is the management. Now, atrial fibrillation, as you know, is the most common sustained arrhythmia we see in our OPDs. Now, what are the clinical features will depend on the mainly palpitations will be there because the atria are beating very rapidly and all the impulses cannot be passed to the ventricles. So palpitation is one of the most common symptoms. The syncope can be there because the heart output atrial contribution to the ventricle is not there. So these are the clinical features. Then the risk of thrombus formation in the left atrial appendage is there. So these based on these clinical features, the management is there. Now management also broadly management depends on whether it is acute atrial fibrillation or chronic atrial fibrillation. Acute atrial fibrillation is of less than 48 hours. Chronic is of greater than 40 if atrial fibrillation is greater than 48 hours. Now in all the acute cases, if the patient is whether acute or chronic, if the patient is unstable, then you have to do cardioversion. But if the patient is stable, then what do you do? Then mainly there comes the concept of rate control. Now the rate control, drugs are the same, the beta blockers, verapamil, diltiazem. So these are the drugs which we use to control the rate. Now then comes the concept of anticoagulation. Which anticoagulants to use? Dabigatran, rivaroxaban, apixaban. These are the common anticoagulants which we use, but there are limitations such as the kidney patients with the creatinine clearance is low. There are limitations of such agents. Then the role of warfarin, and warfarin is very important in valvular atrial fibrillation. Valvular means if there is mitral stenosis or mechanical heart valves, then we only use warfarin, and we cannot use these agents. So this also we must remember because these are the points where the questions are based, and in the question they will give the patient is of mitral stenosis. Then what is the answer? Then the answer will be warfarin. Then so such things you must keep in mind before answering the question. Now there is a big flowchart given here. You can pause the video and see. And but what I have told broadly, those concepts are only required. And then comes the concept of CHA, the CHAD as VAS score, which is important for prevention of stroke in atrial fibrillation patients. And what is the criteria? What is the score above which we give the oral anticoagulant prophylaxis? That we'll see in next part. Now you see that as you see in the previous flow chart that we in the acute cases we do not do oral anticoagulation, but in the chronic cases before cardioversion we have to do anticoagulation for a minimum of 3 to 4 weeks before we go for cardioversion. Now this is very important for you to understand. And now you see that this concept of CHA2 DS2 VAS score. What is this? Now this is for stroke prevention in atrial fibrillation patients who have been controlled, whose rate has been controlled, in which the atrial fibrillation is not there, but the chances of a stroke are higher. So this you have to remember. This is often asked in the PG entrance examination. You must keep a watch on this, and this is very important. Now, in patients whom cardioversion is done, we must anticoagulate them for at least 4 weeks. Now, these patients with atrial fibrillation have chances of recurrences And so, in patients who are often recurring, the option of catheter ablation should be open to them. So now you see that this is in the nutshell the atrial fibrillation and the various questions which have been asked on the basis of this knowledge, which you can apply to solve future MCQs. Now, please do subscribe and like our channel. Thank you.